Hello, everyone. Welcome to week 21 of our series on preventing and managing COVID-19 in the workplace. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. I'm your host. We appreciate you joining us. A lot of you join us every week, and we really are happy that you have been a consistent participant in this session. And for any of you who are joining us for the first time, welcome. During the webinar, you will be on mute. Please submit your questions using the question and answer function in the Zoom application. The webinar lasts about 40 minutes. There's a presentation for about 30 and 10 minutes saved for questions at the end. Any questions that we don't have time to answer, we always answer in writing and post on our website. During the session, Alexis will post access to the questions and answers and also to the recording, which we post on our YouTube channel. Our speaker today, and as always, is Anthony Harris, MD, MBA, MPH. Dr. Harris is our Chief Innovation Officer. He's also our Associate Medical Director for On-Site Clinical Operations and lead clinician for our COVID-19 response. He's an awesome resource, and we're so grateful for his willingness to participate in these weekly sessions. It's getting to be like a well-oiled machine, isn't it, Dr. Harris? So let me turn it over to you. Thanks again.
Excellent. Thank you, Karen, and thanks everyone for joining us once again. Week number 21, and today you're in for a treat. We're gonna get our epidemiology hat on, and we're gonna get our preventative medicine hat on with regard to a strategy that is gonna become more critical to have in place for managing your workforce. So without further ado, keeping the format the same week to week, we'll get into the clinical update, followed by a pathology, microbiology update. We'll jump over to epidemiology, see how we're doing and on the macro and the global scale in the US and beyond. Then we'll talk about prevention. What's the key thing we're trying to prevent this week, and what do we want to learn about with regard to workforce strategies from WorkCare. So when we talk about a clinical presentation as it pertains to updating you, we want to talk about one of the things that has been prominent throughout the COVID-19 pandemic, and that is the persistence of symptoms, right? We all know that we all know what the symptoms are: the coughs, the fevers, the sore throats, diarrhea, nausea, vomiting, right? But one of the things we want to get an update on and clarify is what is the persistence of these symptoms as it pertains to people who have had infection of COVID-19 and have recovered, but still have persistence of symptoms. And when I mean recovered, specifically we're talking about they're able to potentially re-enter the workforce because the level of infectiousness has gone away, but they still may have prolonged symptoms. And so it's an important topic for us to consider. And when we look at our first report examining this topic, it's a study that was conducted beginning back in April. And it looked at retrospectively a number of patients that were admitted to the hospital, recovered, and then a survey was conducted amongst those who were treated for COVID-19 in this recovery group. And if we look at specifically then what the results were for these individuals, about 143 individuals were amongst this study. This study was conducted just out of Rome, Italy. And they looked at specifically, again, those who were hospitalized and recovered. And during this survey, 72% of the individuals who participated had evidence in the hospital, so we're kind of clarifying their severity here, had evidence of interstitial pneumonia. We know that COVID-19 is a pneumonia type of disease. The length of stay in the hospital was 13.5 days, and 21 patients, 15% received non-invasive ventilation. Basically, they needed help without putting a tube down their throat to breathe. And 7 patients, 5%, received invasive ventilation. That means they were on a ventilator with a tube down their trachea, okay, their windpipe. So that gives us a sense of how severe this group was that was examined in terms of their level of symptoms and burden of disease for COVID-19. So at the outset of this study, about 60 days, 60.3 days was the mean follow-up time, right, from the onset of their symptoms. So 60 days after they had symptoms, they were in the hospital. So during that period, their symptoms began, they were hospitalized, they recovered, they were discharged, right? And that discharge specifically met the criteria for WHO discharge or discontinuing quarantine. And that specifically was meeting the criteria during this period of 72 hours had passed with improvement of symptoms, and their fever was no longer present without using any antipyretics, okay? And so if we look at the statistics of what they found, 18%, only 18% of those individuals were completely free after 60 days, right, of any symptoms related to COVID. 32% had 1 to 2 symptoms still persistent, and 55% had 3 or more symptoms persistent, okay? And so this is an update to let us know, and this was published in the JAMA, Journal of the American Medical Association, July 9th, okay? And so it's an update to understanding how people are impacted and to what level they may be impacted persistently after recovering from, in this case, a hospitalization from COVID-19. And if we examine their level of symptom or the specifics about their symptoms, the number one symptom that was present in these individuals was fatigue. Okay, in the dark area, you're seeing during their acute infectious phase while they're hospitalized, after they're recovered, and the persistent symptoms are highlighted here in the lighter teal color or turquoise color. And fatigue was the number one symptom. Dyspnea or shortness of breath was number 2, joint pain number 3, and so forth. Okay, so this is important to pay attention to, particularly as we have more and more of our workforce not just exposed, but contracting COVID-19 potentially, and trying to get them back to work and decreasing our absentee as we talk about managing. So I know what you're saying, Doc. Okay, most of our workforce is not being hospitalized from COVID-19, not being hit that severely. So let's take that and look at then another study that examines a different population of individuals. And so in this case, this study looked at individuals who were not hospitalized but had milder symptoms, okay? And this was published by conjunction with CDC in their Morbidity and Mortality Weekly Report. And what this study examined was amongst those individuals aged 18 to 34, did they have persistent symptoms, meaning did they return to their level of usual health during that period of time after they were tested positive for COVID-19. And so this report found that 35% of those individuals, again in that younger age group, 18 to 34, had not returned to their level of health up to 2 to 3 weeks after they tested positive for COVID-19, okay? And so we're seeing this in a significant way across the board with those who are affected and have recovered from COVID-19 from an infectiousness standpoint, but have persistence of symptoms. So we gotta educate not just ourselves, but the expectation of individuals as well, that this is something we're seeing, and 1 in 5 people who have COVID-19 will still have persistent symptoms 14 to 21 days after testing positive. All right, and we have to have a strategy for dealing with this so that obviously we can manage our absenteeism in the workforce. So let's
Dr. Harris, Dr. Harris, sorry to interrupt. You're fading in and out. I wonder if you can make a little adjustment in your audio. A number of us are hearing you and then you kind of fade away and then come back again.
Got it. That's new. Okay, let me see here. Yeah, I'll try to face the monitor here, and hopefully that will let me know, stop me in about another minute, minute and a half, and see if that phenomenon persists here, okay?
Okay, thank you.
Perfect. So now let's jump into the microbiology, okay? And this is now we're putting on the epidemiology hat. We're getting excited here, okay? We're going to talk about a calculation that is kind of bread and butter from an epi standpoint, but I want to discuss it and kind of break it down because it's going to be germane to understanding the next piece of what we want to discuss, and that's calculating an odds ratio. All right, Harris, what is an odds ratio? Essentially, an odds ratio is the likelihood, right, or the odds that a case of a particular disease that we're looking at, in this case, obviously COVID-19, actually was exposed either to another case or had an exposure at all, okay? And then that is divided by the odds that someone in the control group, meaning no disease, had the same exposure. Okay, and we want to look at this from the perspective of COVID-19 of if you are exposed, what is the odds that something will happen, either mortality or morbidity, all right? And if we look further then at an example, this is not a COVID-related example, but just to give you a sense of what the odds ratio looks like. In this case, the odds ratio, and in all cases, odds ratio, anything over 1.0 means that you have an increased odds or increased risk of that particular outcome you're looking for, okay? And so, for example, 2.2 means that you have a 2.2 greater odds if you have a particular exposure for an outcome, in this case, in this random study that I pulled here. One of the other things to look at is the range in which that odds ratio is being calculated. So from 1.34 in this case to 3.64 is that range for the odds ratio. What you don't want to see is the odds ratio cross 1.0, right? It can't be lower than 1 and higher than 1 and still be significant for either lower odds, meaning it's less than 1, or higher odds, greater than 1. Karen, how am I doing? Am I still fading in and out, or is that improved?
It's better, thank you.
Beautiful. So as we progress, hold that concept in your mind. And let's talk about now, from a pathology standpoint, what we're seeing. Research has shown now that those individuals who have had a influenza vaccine, in this case specifically a trivalent influenza vaccine, have experienced lower risk of mortality amongst those who are infected with COVID-19. This data comes out of Brazil. Brazil has a great history since 1999 of running very effective campaigns for flu vaccinations. Okay, and so what this study looked at was over 92,000 individuals that were confirmed with molecular testing, PCR, for COVID-19. They looked at a number of outcomes, but in this case, we want to specifically look at what is the odds ratio that somebody who has had a flu vaccination, do they have increased odds of mortality, decreased odds of mortality, or the same odds ratio of mortality as those who have not had a flu vaccination? And what they found is that individuals who, amongst all ages, if you received a vaccination, a flu vaccination, trivalent, you had a decreased risk of dying. All right, 0.73 in this case. If they broke that down to those who had a vaccination prior to the 2020 campaign in Brazil and during the 2020 campaign in Brazil, and they saw a decreased odds ratio again there of 0.8. What they also looked at and limited the data to is those under the age of 60. Did they find a similar odds ratio benefit? And the answer was yes, 0.61. So again, Anything over 1 would mean that they have an increased risk of dying. Anything below 1 means you have a decreased risk of dying if you had an influenza vaccination. What we see when they look at the higher risk population, those are 60 and older, they also had a decreased risk of death if they were vaccinated with trivalent flu vaccine. All right, so this is some very surprising but positive data in a large sample size that we want to hold in mind, right? Because this is going to be key as we move into flu season here with our communication to the workforce, not just for flu vaccinations, but for also educating them that it may be beneficial for keeping their families safe with regard to decreasing risk of death if they should contract COVID-19. So very, very exciting there. So now let's put on our epidemiology hat again, and let's go through some of the updates that we look at from week to week. 3.81 million cases was where we were at 3 weeks ago. That increased to 4.2 million last week, and now we're sitting at 4.6, almost 4.7 million cases. The number of deaths has risen as well, up to 155,000 deaths. And if we look at the darkening of the states, when we talk about deaths by jurisdiction, here's where we stood 3 weeks ago. Texas and a couple other states were added to the list in terms of cresting 5,000 or more deaths. And now when we look at today where we're at, that's continuing the trend here of darkening of the states. When we talk about then cases, new cases day by day, this is CDC data that we track along here. We were accelerating almost exponentially here for a while after we had weakening or lessening or decreased social distancing. And you can see where we were 2 weeks ago, where we were last week, and where we are this week. And we're seeing a little bit of a flattening and perhaps decrease in the trend here, which we'll continue to watch and hopefully continue to see trending down. If we look at then how we're doing from a global perspective with regard to other countries in daily new confirmed cases, this is our 7-day rolling average, where we stood back on the 22nd of July, where we stood last week on the 29th. And we continue to see the trend going up here. And now we're seeing a little bit, again, flattening of that curve potentially and where we are today. So now when we talk about deaths, how are things correlating? We made clear that the deaths were correlating to the number of cases increasing. And we saw that trend continue from 3 weeks ago to last week. And now we're seeing that trend still here today as it stands from the statistics on the 5th. When we looked at before, a statistic of what is the share of positive tests when we're out testing in the general public from nation to nation, how many of those tests are coming back positive? This is a measure of are we articulating the burden of disease accurately, or are we underestimating the burden of disease? And so if we look at an updated chart here of that measure, that metric, we can see how, well, first and foremost, how Mexico is doing as they have accelerated cases here and are likely still underestimating the burden of disease there. South Africa, and if we zoom into the US specifically, we can see where we stand here compared to some of our countries across the pond, New Zealand, Germany, Italy, all much lower. So we still have some work to do to get to the number of tests appropriate to better articulate the burden of disease here in the US. So when we talk about the things we mentioned earlier in the clinical review, the pathology review, now let's put it in context in terms of prevention, right? What are the things that we're trying to zoom in on and look at specifically in the workplace? And the answer to that, first and foremost, is absenteeism, right? As we approach the flu season, as we approach the burden of not just COVID illness, right, increasing, but the actual symptomatic population is going to increase potentially because of flu. We have to figure out what is the best way to evaluate these individuals and get them back to work safely without ballooning the absenteeism because everybody's staying home with presumptive COVID. right? And obviously with COVID itself, dealing with it in a very efficient way to decrease and better manage our absenteeism. And so if we look at this study that was published by CDC, looking at individuals from March to April, we're looking at the absenteeism that we would normally see at this point, and then any increase in that absenteeism as a result of the epidemic and pandemic that we're currently experiencing. And this study and data came as a result of something the CDC does routinely in conjunction with the Bureau of Labor, okay? And the process and the data came about from a survey that's conducted with over 50,000 households on a routine basis. That's where most of our statistics come from the labor force, right? And so when we look at this data, we're looking at that statistic, looking at the survey that was conducted here recently this year during the pandemic. It started at the end of last year, October through December, and continued January through April. And they look at different industries. They break down these stats into different industries. And so the question asked and answered in this was specifically, is there higher than normal absenteeism as a result of COVID-19 amongst the workforce? And the answer to that is yes, in some specific industries.
Dr. Harris, we can't hear you again. Sorry, interrupt.
That's okay.
Getting a lot of comments about how you're fading in and out again.
Okay, got it. That may be something related to my connection here. Let me look at my microphone array and see if it. All right, can you still hear me now?
Yep, can hear you now.
Okay, so we'll see if that's improved here with performance of the microphone. Again, stop me again.
Just please. When I said we were a well-oiled machine, I think I jinxed us.
Well, hopefully over the next couple minutes here, as we finish up the last two segments, it'll be improved. Again, we'll check in.
Yeah, sorry, I have to keep interrupting.
That's okay. We'll check in again. We'll check in here in about a minute and a half. So the answer to this question of is there in fact increased absenteeism is yes, in some specific industries. Across the board, what was seen was a slight increase that was not significant if you put all comers together in all industries. But if you limit the data to the industry of personal care and service occupations, there was a significant increase there from an absenteeism around 2.0 all the way up to over 5.0. If we look at healthcare support occupations, those in nursing homes as well, we saw an increase that was significant there. And then if we look at the percentage in the workforce that were, if we look at absentee in the production occupations, these are the meat packing industries, food preparation, et cetera, we saw a significant increase there. And so what we can draw from this is that if you are operating in a essential workforce, right, you had a higher likelihood of having increased absenteeism amongst your workforce, right? And so obviously having strategies to manage that absenteeism, to limit that absenteeism is going to be critical as we continue to deal with COVID for easily over the next 5 to 6 months before we get into next year of any hopes of a vaccine, right? And so as we talk about then the strategy moving forward and best practices, I'll pause there and ask, how's the audio? Is that improved?
I'm hearing you okay.
Perfect. All righty. So the workforce strategies then that we want to address and we want to zoom in on is, and I can hear those asking perhaps in the background here, right? Hey, Doc, I know what you're talking about, but hey, we got all the pieces that you've been preaching here with regard to prevention. We got the daily screen going. We got our remain at home, being flagged for the workforce. We're doing the COVID testing that you have recommended. That's in place. And maybe we're even figuring out local testing as well in terms of providing providing access to workers in an effective manner. And we even have a return to work protocol in place, right? So we got all the pieces, Doc. We got it figured out. But what we want to make sure of is the process that has we'll call it an anomaly or a breakdown. And that process and breakdown looks a little bit like this. And this is what we're seeing anecdotally across the board in multiple industries. We're seeing those individuals who are having persistent symptoms. We're seeing those individuals who are having prolonged PCR positive states, right, in terms of getting them back to work. We're seeing repeat quarantines, those individuals who, hey, I'm quarantined for 10 to 14 days, and the very next, couple days after being back, guess what? They're quarantined again and again, right? And then we're also seeing those individuals who truly are having an impact in terms of health and wellness, and now have limitations as a result of their impact from COVID-19, right? And so what is the answer to these type of presentations that we're seeing? And it is Fitness for Duty, FFD, right? And so we want to talk about briefly here, how can Fitness for Duty help us specific to COVID-19? And yes, we want you to have a specific plan in place regarding Fitness for Duty and the impact of COVID-19 on your workforce to prevent these type of anomalies from growing, from being an impact to absenteeism in your workforce. And so if we look at then the approach to Fitness for Duty, it's not going to look too different from what you may have experienced already with your Fitness for Duty program. It begins with employee education, allowing them to understand, look, this program is specific to our Fitness for Duty with regard to impact of COVID-19, and we want to help you participate in it so that we can identify how we can better help you, right? Better help you get back to work, or and if you need accommodations, how do we help identify those and provide that service to our employees, to our workforce. It's followed by a HIPAA release that we can access patient records from a personal doctor. And then our physicians have been conducting interviews of the employees telephonically because of the limitation of getting people in a clinic. Obviously, is still a barrier with regard to COVID-19, but we're able to perform an in-depth interview of the individual and determine a history of what has happened, what has transpired with regard to their impact of COVID-19. And then we want to get a thorough job duty evaluation of what it is they were doing before and what it is they're likely to be doing afterwards with regard to returning them back to their workplace. And then we want to look at specifically those clinical findings that may be appropriate to COVID-19 and they may not be, right? And these are some of the key considerations we want to discuss here in a moment. But then the Fitness for Duty determination is going to resemble, again, a determination that you're used to. Yes, this individual has underlying pre-existing condition that has affected their ability to safely return to work as it pertains to their COVID-19 exposures. Or no, this individual does not have any significant findings that support them being out longer than they already have. Right, and so we can provide that expertise drilled down and specific to the COVID-19 experience for individual to individual, and that's how we've been able to help with managing the workforce and absenteeism. And so lastly, what are some of the key considerations as you now hopefully endeavor to create a process for managing Fitness for Duty as it pertains to COVID-19? We have to first and foremost look at the causality, right? If we miss this piece of it and really do a good job on causality, if we have findings that are significant, if we have impact from COVID-19 that's significant, and it was work-related in terms of transmission, obviously that may result in some increased disability, increased litigation, if you would, long-term with regard to someone's, hopefully not death, but we've seen it, but long-term morbidity if they have limitations. So we want to get that piece right up front. When we talk about then those things that are specific to COVID-19 with regard to long-term issues, the sequelae, or were the symptoms that they're experiencing and continuing to experience from a pre-existing condition, that determination has to be made and be made well so that we're not attributing current symptomatology to COVID-19. And that, again, across the board is going to be critical to ensuring that your workforce is back safely, but you're not carrying an increased risk and burden inappropriately. When we talk about ongoing risk from a workplace transmission, those individuals who are testing longer for molecular PCR tests, those individuals who may be symptomatic for much longer than what we're seeing, what is our strategy for getting them back? Are they sitting out for weeks and weeks? We're seeing that 6 weeks, 9 weeks, or longer. How do we get them back and how do we get them back safely? The fitness for duty process can do that examination in a tight, succinct fashion. And then finally, pre-existing risk factors for prolonged or repeat quarantines. This is going to be critical for, and we see it all the time, unfortunately, in this business, right? Those few individuals, the vast minority that want to game the system. And we want to make sure we have a process in place to identify those individuals who may have secondary gain from staying out and not coming back to the workforce appropriately after being quarantined once, twice, or 3 times or more. Right. And so again, the fitness for duty process can help evaluate these individuals and help maintain continuity when we talk about absenteeism. All right, so we've covered a lot today. Hopefully it was a fun day. Pardon the audio issues here. We'll fix that moving forward. But now let's go ahead and move on to questions. Thank you.
Thanks, Dr. Harris. We'll jump right into the questions. There's one about referencing your comments about the odds ratios and clarification on that. The question is, are you certain that they chose OR over RR? I see they stated odds versus risk, but I struggle to understand why they would choose OR with an N equals 92,000 plus.
We'll have to get more specific into the methodology. That's a little bit beyond the scope of this discussion, but happy to follow up with you afterwards to talk about odds ratio versus relative risk and their approach and their methods for sure. So
that's an anonymous question. So if you want to send me your question, whoever asked that, I can forward that on and Dr. Harris can address it in more detail. My email is karen.o'hara@workcare.com if you want to follow up. You've answered this question before, but it probably bears repeating relative to testing. Should employers consider requiring a second COVID test if the employee went to a drive-up facility where they completed their swab test themselves?
Yes, in most cases, the requirement still is 2 negative tests to decrease the sensitivity and specificity, or excuse me, to increase the sensitivity and specificity to a level that you can make a determination, a clinical determination. So usually at this point in time, 1 test, given the specific circumstance, is not sufficient to clear someone in and of itself from the quarantine or self-isolation. Now, again, the clinical context needs to be critical in that evaluation. So if we're talking about just the test and using that as a primary determinant, please use 2 tests, not just 1.
Okay, so this next question is relative to the answer you just gave. The questioner says, we're having better luck finding specificity and sensitivity information to employ a single test COVID strategy. In addition to the Harvard information that you previously provided, many of the manufacturers are now posting PPA and NPA data on their websites. PPA and NPA seems to be used interchangeably with sensitivity and specificity, respectively. Can you comment on this correlation?
Sure. So the PPA and NPA statistics do vary. okay? And perhaps this can be a point of topic moving forward. But the data that's being published is data that is captured typically by FDA during the submission of these tests to get cleared. And what the PPA and NPA are referring to is an agreement process. So what the manufacturers of these tests will do is create what are called contrived tests and contrived samples. They take a negative sample for COVID-19, they spike it with COVID-19 proteins, and then they test it. And usually they're testing it at starting at 2 times or 2x the limit of detection of a particular test. And then the outcome they're looking for is, hey, did our test identify this as a positive sample or as a negative sample? And those tests in which they used a negative sample, did our results come back negative and match that? And that makes up the NPA and PPA data that you're referring to. And it can be used to identify some of the accuracy that we're looking for. However, what we also look for in terms of vetting a particular test is clinical data, meaning they took samples that were confirmed otherwise with molecular tests from patient and then tested those in their process. And were they identified as positive? If not, were they identified as inconclusive or identified as negative? And typically you'll find a difference between the NPA and PPA data that is published and any clinical data that may be available. So take a look if in the clinical data on the second hand is the more difficult to find data on these particular tests.
Okay, this question is related to a specific type of test that WorkCare is providing at a limited number of work sites. How long after exposure does it take to have a sufficient viral load to register on an antigen Sophia Quidel test? For example, if someone traveled to a work location and was tested a couple of hours of exposure on a plane, would it show up on the test?
In short, no. The answer to that second part of the question, no. In hours after exposure, we know that any molecular test or antigen test will not not likely to result in a positive confirmation of COVID-19 because the virus has not replicated sufficiently to the limit of detection of basically all the tests that have been on the market. And we talked about this in a previous presentation, I believe 2 weeks ago, looked at, or maybe even 3 weeks ago, looked at what's the earliest we should be testing individuals after an exposure. And the answer to that across the board is at the earliest 4 days, 5 days, ideally, and using that methodology, even with the consistency of antigen tests, is best practice for now. Now, there are situations where we are testing individuals on a routine basis to help limit any recent infection within that appropriate timeline in which they can transmit the illness. And what I mean by that is, if we can't detect it, it's too early after a potential exposure and transmission, typically someone does not become infectious during that time period either. And so the goal of testing is to identify when somebody is likely to be infectious, and that timing is critical for both ends of that.
We have time for one or maybe two more questions. This one asks about adjusting your response. I presume this is based on the model you've presented for evaluating fitness for work. How do you adjust your response to COVID-19 due to the inconsistencies in testing in the workplace?
Sure, so the testing is only one component to the entire evaluation, right? So the fitness for duty evaluation, as the return to work evaluation, as specific to COVID-19, is a clinical one. and that's backed up by CDC and their larger move to have clinical clearance of individuals versus testing clearance of individuals. So when we, in context, look at the different types of tests being done, one, we do want to try to capture what test was done. Was it a molecular or antigen? Was it an antibody test? That is relevant. If we have data on the accuracy, also relevant to the clinical determination, but certainly in context, we have to consider on the full clinical picture of symptomatology, onset of symptoms, severity of symptoms, when we talk about our process for evaluating fitness for duty, as well as return to work. And so regardless of the specific tests, those other points are going to be salient for understanding, is someone safe, is someone fit?
Okay, and to wrap up, there's a question about schools, which is on everyone's mind. Just your opinion on how you think reopening of schools may impact the case numbers.
So when we talk about schools, and we're talking about it across all schools, right? Those collegiate and as well as primary, we know that the younger demographic are more likely to be asymptomatic. And we know that the extreme of that younger demographic may be less compliant with social distancing and wearing the necessary PPE, right? And I'm speaking in regards to my 3-year-old who we're considering should we send to preschool or not, or do it virtual. So from across the board, are we likely, and this is Dr. Harris' opinion, right? And also backed up with other data, are we likely to see an increase in COVID transmission as a result of more students being back and in person? My opinion is yes. And when we talk about, is it safe to send your child? Then we're now talking about a very specific, very local determination, given the local transmission, rates of transmission and prevalence, and then also given the precautions that may or may not be in place for that specific institution. So across the board, at the macro level, yes. At the micro kind of determination, it depends. And it's going to be individualized in terms of approach.
Okay, we're out of time. As always, Dr. Harris, we really appreciate your insights. And to all of you out there who joined us this week, thanks again for being part of this process. And we want you to all be safe, wear your masks. Thanks, Dr. Harris.
Thank you. Thank everybody. And we'll see you next week. Same time, same place.